So we're going to talk about stroke today in sickle cell, um, not from a cardiovascular disease standpoint, but from a sickle cell standpoint. Um, all right, so we're going to talk a little bit, and there's different terminology that's important to know, like overt stroke and silent stroke. And the way we're going to go through this is just sort of explain just the landmark studies that led to, best practices for stroke management. So in terms of overt stroke and sickle cell disease, it occurs in about 5 to 10% of children. It's going to get larger, though, throughout life. It can be thrombotic or infarctive event involving large intracranial arteries, and you guys, I assume, would know how strokes present at this point. The problem is, right, we can get neurologic damage and long-term disability. And so, unfortunately, I know, at least being in pediatrics, we have a few of our patients who have significant long-term disabilities from their stroke. So in terms of the epidemiology, this is an old slide, but just sort of letting you know that this can happen throughout life. So on the x-axis is your age in years, and in the y is proportion without a stroke. So going down that y-axis means you have a higher incidence of stroke. So you can see even in pediatrics, that's where we get our 5 to 10%, because between 10 and 20 years of age, about 5 to 10% of our patients will have had an overt stroke. Now, the hope is this is better because of stroke screening and novel sickle cell medicines. Now, patients with S beta 0, S beta plus SC also have stroke, but just they have a little bit delayed onset in the development of their strokes. So one of our goals is to prevent an overt stroke, and that should be an obvious statement. And so this is where we do transcranial Doppler ultrasound screening, or as Dr. Cantor has rebranded, stroke screening. And again, the reason is we're trying to identify who is at risk for a stroke and intervene early. So we have this transcranial Doppler, and it's going to measure flow velocity in the large intracranial arteries. And so, Chibuzo, do you want to tell us about Bernoulli's principle? Or does anybody remember Bernoulli's principle? So Bernoulli's principle, again, is some mathematical equation about velocity.
But I don't know, but I don't remember.
Okay, but the key point about Bernoulli's principle is one part of the equation is 1 over the radius times to the 4th power, meaning as your radius gets smaller, or as arteries, get sclerotic and smaller, that in itself is going to raise velocity. So that's why patients who have large vessel stenosis will have higher TCDs, and that's also an issue for stroke screening. There's also a physiologic component, most likely, in which if your blood flow is not going well to the brain, then you need to increase blood flow velocity. And so the combination of 1 over r to the 4th and oxygen sensation in the brain makes your blood flow go faster. So most clinical strokes occur in children with SS who have increased TCD flow velocities. And so what we've come up with is a protocol in which we evaluate TCDs. There's 2 different types. It's called non-imaging and imaging. And again, you don't have to remember these things. But what you should know is that the higher the velocity, so in that first column, we think that if the, blood flow is going greater than 220 centimeters per second on a non-imaging, then those patients, we go ahead and we just start treatment and get an MRI, MRA. If it's above 200 on non-imaging, then we go ahead and repeat it. And if it's abnormal, then again, we start transfusion therapy, and we'll go through this. So again, if you are out in primary care practice, and most likely you're not going to be doing TCDs on sickle cell patients or stroke screens on sickle cell patients. But again, it's going to be critical that you reinforce, because Dr. Cantor's data, and she can correct me, but I think it's around 50% of patients did not have appropriate stroke screening from 2012 to 2016. I think 70% of patients had 1 stroke screen within that 2012 to 2016 time, but there were patients during a 4-year time, and this is national data, who did not have a stroke screen performed. If the stroke screen is normal, then we can go ahead and repeat annually. So the ASH guidelines are going to tell you this, which is if you have a child with hemoglobin SS or S beta 0 thal, that we recommend annual stroke screening. Now, the issue, again, why don't we do this in all patients is, again, a transcranial Doppler is an echo. So it's not that screening is not important after age 16, but usually the bones thicken up by that point, and it's hard to go ahead and get a valid exam after you get really thick bones. Now, this is for SS S beta 0. If you have, there's other forms of sickle cell, SD, all these beta mutations. So if you have one of these heterozygous forms of sickle cell other than SC, but you act from a hemolysis or anemia standpoint, just like SS, then again, the suggestion is going to be to go ahead and screen those patients with TCD. So why do we do this? So again, if not, I'll have to pick on Dr. Alonze. So who would like to interpret, again, this has an important stamp on the bottom, which is New England Journal of Medicine, meaning it was a potentially landmark study. So this was a study where we took patients with an abnormal TCD and they got randomized to transfusion versus standard of care. Would anybody like to volunteer how they would interpret the outcomes comparing standard of care versus transfusion for an abnormal TCD? All right, Dr. Alonze. We'll even highlight the importance. So
yeah, the importance is that like transfusions helped prevent stroke.
Yeah. So again, in this interpretation of the figure, they have 67 patients for a total of 1229 months, but really most patients were on the study for about 1.5 to 2 years. And that's where you can see the median and mean time of follow-up. So if you had an abnormal TCD at a mean of 18 months, 11 of those 67 patients went on to have a stroke. Whereas if you were on the transfusion arm, 1 patient had a stroke. And so I believe this is one of the many sickle cell studies we've done. So in clinical trials, we have a data safety monitoring board who evaluates what we're doing. And you can imagine if you're evaluating this data, you would say, we are going to stop the study because we feel at this point that we have statistically proven that transfusion is superior to standard of care, and we no longer want to put patients at risk for not receiving transfusions. So that's been the standard of care for a while, was transfusions if you've had an abnormal TCD. Now, the nice thing is when you have the stroke screen that's abnormal and you get on transfusions, your level of measurements on your TCD go lower. So they go back to the normal range. So the question became, do you need to remain on lifelong chronic transfusions? Because there are problems with chronic transfusions, and that a lifetime of transfusions means most likely you're getting lines placed, and lines can be associated with clots. Also, lines can be associated with infection. And then importantly, which we won't get into this talk, we have a risk with alloimmunization. So even though current technology makes us think that we have very good screening methods, we actually don't do a great job in terms of being able to detect certain alloantibody formation, especially in the Rh blood groups. So the question then becomes, can we do hydroxyurea instead of transfusions? Now we'll get to the other study, which was called SWITCH, but they use a very similar protocol. But for this, what you need to remember is this is a treatment protocol where patients were already on transfusion for an extended amount of time, and they had a normal MRI, or they had a normal MRA in particular. So if somebody has an abnormal TCD, the standard of care is still to go on transfusions. However, after a specified amount of time, if your MRA is normal, then we can now interpret this data, which again is hard because I don't have in here the standard versus alternative. But if you look at figures A and B, one of those is on hydroxyurea, one of those is on transfusion, and you can see that statistically, they did not show any difference between the two. So putting those things together, what we say is that if you have had an overt stroke, it's going to be transfusions for at least a year with a goal to maintain the hemoglobin S below 30 and a hemoglobin greater than 9. So clinically, what does that mean for you? Your patients should get a transfusion to drop their hemoglobin S level low and to improve their hemoglobin. But remember, you're making a whole bunch of red cells every day. These red cells that endogenously a sickle cell patient is making sickle cell hemoglobin. So if you just were to transfuse somebody to 30%, by the time they'd come back in about 4 weeks, that hemoglobin S would be much higher. So we actually try to get them to around 15%, so that way when they come back in 4 weeks, it's still below 30%. And then if you've been receiving transfusion for at least 1 year and you are interested in stopping transfusion, you need to have that normal MRA. And then it says we can suggest, it's a suggestion that hydroxyurea treatment could be substituted. So again, if you have an abnormal TCD, we go on transfusion for a year, and we could consider hydroxyurea. Now, all of this means we are trying to prevent a stroke. So if you get a note from Dr. Cantor or myself, or Dr. Alonze, and it says primary stroke prevention, what you want to remember is this portion of the talk, because that what means is these children or adults have not had a stroke, but they've had a history of an abnormal TCD, and therefore the primary stroke prevention is to prevent that first one. If you see a note and it says secondary stroke prevention, we'll go through that one. So again, this is a very important study. It has Journal of Pediatrics. On the x-axis, it's going to be time to a second stroke, and on the y-axis is probability of no recurrence. So if you had a patient with a stroke, again, we randomize patients to either with transfusion, which is the dotted lines, or without transfusions, which is the solid lines. And again, unfortunately, for those of us who are used to Kaplan-Meier in the stroke world, it seems like they keep doing going down means worse. So what we see here is that if you have not been randomized to transfusion, your probability of no recurrence at, and we'll just pick around 36, so 3 years, about 30 to 40% of patients would not have a recurrence, meaning 60 to 70% would have a second stroke. So again, you could imagine from this study, the standard of care becomes, we want to move to transfusion therapy because at 3 years, it is not perfect transfusion, but again, only maybe 10% of patients, if we look at that 3-year standpoint, would have another stroke. So the question rose, can we try hydroxyurea? So hydroxyurea, again, this was what we call there was a dual endpoint of trying to reduce iron overload, which is the benefit of not being on transfusions, but also looking at hydroxyurea transfusion. And so I won't get into the complicated stopping rules, but just so you know, it was stopped for actually not reducing iron overload. The problem is when they stopped the study, they had 7 strokes in the clinical trial, and all 7 strokes were in the arm of hydroxyurea. Now, they tried to figure out why this happened. They think maybe younger age at initial stroke, if they had a TIA. A big one that they thought about was this severe vasculopathy. And then if they have alloimmunization, all those may be associated with the increased risk of stroke on hydroxyurea. So when we do clinical trials, we always have to make up what we think is a non-inferiority margin. And so we thought, we knew that transfusion was probably going to be better than hydroxyurea. But the question is, if you can dramatically reduce iron overload, then again, in the ethics of medicine, we felt it was okay for a few patients to have additional stroke if that meant all these patients did not have to be on transfusion for the rest of their lives. So the rate difference between stroke and non-stroke was still within the non-inferiority margin. But when you look at the actual scoreboard and they see 7 strokes in one arm and 0 strokes in the other arm, that's why a lot of people now still would consider transfusion to be superior, even though it was not proven in this study. But the thought is if the study had continued, it may have hit superiority. So that's why the official guidelines is going to say, if you've had an ischemic stroke, the panel is going to recommend blood transfusions. Now, the issue that we will have in clinical practice, though, is the problem of chronic transfusion therapy for secondary stroke prevention, meaning patients have had a stroke, we put them on blood transfusions, is over time they may develop iron overload. And the most common reason patients get iron overload is they do not take their chelation medicine. So clinically, we get into this dilemma, well, what do we do when a patient who's not taking their iron overload medicine now has marked iron overload? Well, only 6 of those or 7 of the patients on the switch arm had a stroke. So it seems like it is still better than no treatment. But we get in this ethical dilemma of, if we continue transfusion therapy, we may cause marked liver, damage from iron overload. So let's try to switch to hydroxyurea. The problem is, if they're not willing to take their iron chelation medicine, are they willing to take the hydroxyurea? And we know that if you stop your hydroxyurea and transfusion for somebody who had a stroke, the risk of a second stroke is going to be very high. So again, when you're seeing patients, if you see for secondary stroke prevention, always reinforcing the importance of iron chelation and maintaining their transfusions. Now, another thing we see is a silent cerebral infarct. So these are, depending on who you want to look at, 2 to 3 millimeters lesions. They're right here, these hyperintensities on T2 flare. But the patients clinically have a normal neurologic exam, or at least an abnormality on exam that cannot be explained by the location. So they can have something, but if it's not in the location of the lesion, we call that silent. And again, this is going to be something that's very prevalent. So on this is an epidemiology from different studies, which they put into one figure here. On the x-axis is age. On the y-axis is the prevalence of silent cerebral infarct. So in the baby hug study that we did of infants, we had an 11% incidence of, or prevalence of the silent cerebral infarct. The SIT trial showed that around teenage years, about 30%. In adult studies showing about half adults having a silent cerebral infarct. Now, again, there is potential bias because these are in patients who get screened, and there may be reasons to screen certain patients but not others. But again, I think the data clearly shows that it is highly prevalent. So there was a clinical trial, and again, the thought was observation versus transfusion. So if you've had a silent cerebral infarct, should you be on observation or transfusion? And this study demonstrated a reduced risk of an endpoint if you were on transfusion therapy. Now, some people would also like to be critical of that, because if you want to say silent cerebral infarcts reduces the incidence of new silent cerebral infarcts, when they look at that number 7 to 5, they may say, we're not convinced that transfusion is going to prevent new silent strokes, but the data would support that it's going to prevent a silent stroke progressing to an overt stroke. So transfusion, again, always is a great treatment for sickle cell. But the issue is, again, if 50% of adults are going to have a silent cerebral infarct, do we really have the capability to transfuse 50% of our population? Same thing in pediatrics with a third of ours. So we tried to do a study of hydroxyurea to prevent silent cerebral infarcts. This was our study here. 3 of our 27 had a silent cerebral infarct. If you look at St. Jude data, 1 of 19, whereas none of our patients who were on hydroxyurea had an overt stroke. So we combined that, and we showed it was 8.7 versus 0%, and compared that to the observation arm of the SIT trial and the transfusion arm. So when we do clinical trials, we now say, okay, this is our expected hydroxyurea, maybe 8% new events, about 6% new events, and we decide, can we do a randomized clinical trial? The answer is no, not because we can't do it, but because it would require 3,330 participants with an 85% power and 5% significance level. So we looked at that and said, we have barriers to enrolling in clinical trials, and we felt that enrolling 3,330 participants was not going to be feasible, nor importantly for clinical trials would not be funded, because that would be a large sum of money. So we are sort of left now with this question of how to treat silent cerebral infarcts. So what we do is we put our patients we give them the options of either transfusion or hydroxyurea, and then we repeat imaging. Now, again, the SIT trial may say, transfusion by itself may not prevent new silent cerebral infarcts, but if somebody is having progressive silent cerebral infarcts, we evaluate every year and then, again, give them the risk benefits of both options, but we do not feel like no treatment is appropriate for silent cerebral infarcts. So in terms of screening, all our patients should be getting MRIs. I think I lost that next page. Sorry, I lost the next page. But again, our treatment would be, as I said, we either offer hydroxyurea or transfusion, but we feel like no therapy is not appropriate for silent cerebral infarct. Now, last, we'll just end with neurocog, because again, these are issues, but will it impact people's learning ability? And yes, so silent cerebral infarcts do impact children's ability to learn. And this is looking at what we call a forest plot, where they take different studies. And again, these may all have different inclusion, exclusion, but to the best of the, this meta-analysis opinion, they sort of could all fit together. They look at neurocog outcomes and showing that the sickle cell patients in general have worse impact on learning. Therefore, we should be also screening our children for learning issues, or adults as well. And we should be providing neurocog rehab. So then I'll end with acute stroke management. Again, patients are going to come to you acutely for stroke, and just sort of thinking through, if you have a patient who has come with an acute stroke, in terms of management. So there is a differential for stroke. And again, it would be common to many other things, but again, both ischemic and hemorrhagic strokes. So somebody could come in with an acute stroke look, but then it resolves within 24 hours. We call that a TIA. Making sure it's not a seizure or migraine. Checking blood pressure. When you scan, you may see this PRES, or posterior reversible encephalopathy syndrome. And cerebral sinus venous thrombosis can also present similar to a stroke. These are just suggestions for orders in the ED depending on your age, but obviously getting a CBC. Now we'll talk about the management, but the goal is to type and cross when they come in so that you have blood ready. If you can, getting a hemoglobin S percent, because that again will help us in our management. Checking a renal panel, if you want to check coagulation studies, especially if it's a hemorrhagic study. And you want to venous access, and preferably with a large, in this case, they're saying here, 7 French double lumen if we're planning on pheresis. MRI, the brain without IV contrast, is a preferred order. So if something's going on within a 10-day period, DWI can help differentiate acute from old strokes. It could be normal, though, within the first 24 hours. If the MRI is completely negative, that's again when you want to start thinking about migraines or PRES or CSVT or Todd's paralysis. So what we see a lot of times is people feel like, oh, we can't get an MRI in the middle of the night. If you can't, go ahead and get that CT. We'll exclude hemorrhage, but really not going to exclude a ischemic stroke within the first few hours. The later they present, then a CT can pick up some ischemic strokes. And then also, again, looking for MRA, and you may want to consider MRV if you're concerned for CSVT. And finally, what's the treatment for acute stroke? So again, we use oxygen, but really transfusion therapy is the gold standard for acute stroke. There's different ways to transfuse, but what our goal is going to get our sickle cell level low. Have we done a transfusion talk on here, Julie? Okay. So again, the rule of thumb, now I'm in pediatrics, so I don't know if it's the same for adult, but what we want to be doing is we take out, as much blood of the patients as we can, and then we give back blood, because that's the easiest way to dilute a patient down to a sickle cell level less than 30%. So to do that, we have these machines, they're called pheresis machines. If you assume let's say you don't know a sickle cell patient's percent hemoglobin S, let's just assume it's 100%. So if you left a patient with an FCR, that means the fraction of cells remaining. So if only 30% of the cells at the end of this procedure are their own, if they started with 100% S, well, we want their own cells to be less than 30. We want 70% of the cells to be transfused with no sickle cell. So that's our goal, is again, to remove their cells so that their cells remaining have a hemoglobin S less than 30%. To do that, a rule of thumb for us in pediatrics is we ask for 1 unit per every 10 kilograms. So if you have a 50 kilogram child, that means we probably want 5 units, but to be safe, when we go back here and we say, hey, we want to, tell you how much blood we need ready, in a 50 kilogram child, we would say 6 units should be appropriate to get this down. If you do not have access to pheresis at your hospital, then let's go back to this. If we can't exchange transfusion immediately, then the question is, can we perform a simple transfusion? So if the hemoglobin is less than 10, our goal is to do a simple transfusion to get that hemoglobin to around 10 while waiting for an emergent exchange. So if you have room to give a transfusion while waiting for an ambulance to get the patient to a place with pheresis, again, I'm sure we'll be talking by phone, but again, going ahead and getting blood to the patient as soon as possible. And with that, I will open it up to questions.
That was great. Anybody have any questions? I think one of the most important take-home lessons I can give everybody just from some of my experiences is that I've seen on several occasions where, especially in community hospitals, people are so focused on transferring a patient that needs an exchange transfusion as opposed to treating the patient while you wait or we run into trouble. So remembering specifically that there's plenty of opportunity for simple transfusion, and that if their hemoglobin is really less than 7, simple transfusion's always the way to go, because you can't even get them on a machine. So making sure that you're not so focused on trying to transfer them that you're not treating the patient in front of you. I've seen that several times. All right. Well, any questions from this very quiet group? Well, if not, thank you, Dr. Lebensburger, and everybody else. Please keep your cases for us. We would love to have some cases to discuss. I can't imagine we're doing that great a job of keeping everybody out of the hospital. So make sure you keep an eye on those cases, and we will chat soon. Thanks all.
Thank you.
Doctor, I have a question, Jeff. This is Humming Mobile. I just joined in the middle of your talk. I'm so sorry, but I have a question about the SIT child and the transfusion. So, I mean, kind of that study from Michael Dubon suggested at least 3 years of transfusions. So, I mean, your experience, the patients you have you had a total of 3 years, and then you've stopped the transfusion and just continued with hydroxyurea?
So no, we'll go again. It's in the absence of data, right? Because ours is just retrospective data. But yeah, we have put our patients on transfusion. I mean, on hydroxyurea, without doing the 3 years and then switching over.
I see. And did you do a follow-up MR or kind of neurocog to see if the things are stable, improving, or not worsening?
Yeah, so that's what we try to do, then annual MRIs, and at every MRI, and I'm just trying to pull up the manuscript real quick as we're talking. Then we, if it's progressive, then we again offer them transfusion therapy at that time.
So then after that, you do the yearly MRs. Okay.
Yeah, so we'll do annual MRIs.
Yeah, and we do the same thing on the adult side. And if not annual, then every other year, just based on timing. But a lot of times we have found progression, and at that point, people who maybe weren't willing to do transfusions then are more interested in doing them.
Can you see my screen now?
Yes.
Yeah, so again, we offer, you can see, at least in our practice, the majority of people select hydroxyurea over transfusion, but we give them both options.
I see.
And again, that's a question, right, we have is, and this another issue we have is, right, if a patient is on hydroxyurea for 12 years, we get their first screening MRI and they've been on hydroxyurea, say, for 4 years, they're a 10-year-old, and they have an MRI that shows a sign cerebral infarct. Yeah, we also then have that question, like, did it happen on hydroxyurea? Did it happen prior to hydroxyurea? And so that's what some of this is sort of saying, like, for those even though who are on hydroxyurea at the time of their first MRI, who then had a sign cerebral infarct, a lot of them still preferred being on hydroxyurea.
I see. And you do your first MR, at 10? The screening MR?
We try to do it. I was just giving an example. We try to do our first at a non-sedated time. So again, for those on the call for children, you need sedation to get an MRI, because you can imagine a 4-year-old will not sit still for a 30-minute test. So what we try to do is a non-sedated MRI, which depending on the, whatever attention versus emotional, abilities of a, 4 or 5-year-old could be anywhere from 4 to 6 years of age. Usually by 6 to 7, they'll sit still. So we try to do our first one non-sedated, in that age range when a parent feels like, yeah, my kid will now sit still.
So I would agree. We also do around 6 or 7. Thank you.
Uh-huh.
Awesome, thank you. Any other questions? Going once, going twice? All right, thanks, everybody. See you in a couple weeks.